Hi, my name is Regina LaBelle. I am the director of the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown University Law Center. In addition, I'm the director of a new Master of Science program at Georgetown University's Graduate School of Arts and Sciences. This program will begin next summer, and the purpose of it is to train a cohort of individuals in addiction policy. I want to thank the Public Health Institute and University Hospitals in Cleveland for hosting this important conference. And I was able to listen in briefly to the folks from Huntington speak about the great work that they do in that community in West Virginia. So I'm really happy to be here to talk about this important issue. And my remarks tonight are going to focus on from rescue to recovery. And I want to pause a moment to recognize that we're entering the third decade of the overdose epidemic. In 1996, OxyContin, a long-acting opioid, was introduced to the market by Purdue Pharma. And this product really lit a fire of opioid-involved overdoses, driven by a combination of illegal marketing and distribution practices around the country, targeting specific areas of the country, particularly in the Northeast and the Southeast parts of the country. So children born at the beginning of the first wave, what the CDC has referred to as having 3 waves of the epidemic, are now in their early 20s. The last decade also saw an uptick in foster care rates, especially in areas of the country with high rates of opioid use disorder. And these young people, some of whom had been raised by other family members, but others who were entirely separated from their families, may now be at a point where they're aging out of foster care. And ages 18 to 25 are a transition period that's often marked by higher rates of substance use and the development of substance use disorder. Trauma experienced by young people in their formative years, which can include a separation from a parent, perhaps insecure housing, and other societal factors, combined with genetic factors, place this cohort of individuals at higher risk. Now, I began working at the Office of National Drug Control Policy in 2009, and this is the office in the Executive Office of the President that is charged with overseeing drug policy for the federal government. At the time, few people were aware that overdose deaths surpassed car crashes as a leading cause of accidental death. And a decade later, life expectancy in the United States decreased, partially due to overdose death rates. So moving from rescue to recovery means recognizing that addiction in the United States is not an acute condition that we can easily fix. Rather, the overdose epidemic we're now experiencing really is part of a much longer trajectory of increasing rates of overdoses that began in the 1970s. So the substances may change over time, but the chronic issue of substance use disorder, and particularly untreated substance use disorder, remains. The substance may be pills, heroin, illicitly manufactured fentanyl, or a combination of substances that includes alcohol, cocaine, or methamphetamine. Substance use disorders are chronic conditions demanding a sustained long-term response. But the way our nation often approaches this chronic condition is by punishing people for the underlying condition. And I'm thinking about this in terms of how at the Office of National Drug Control Policy, we worked on the issue of transnational organized crime and drug trafficking. So the techniques for identifying drug trafficking networks, you identify, you charge, and you punish in an effort to disrupt these drug trafficking networks. And unfortunately, it appears that we are seeming to apply the same method to the public health part of this addiction. You identify someone with a substance use disorder, and then you punish them in an effort to disrupt their condition. But public health officials, addiction professionals understand this doesn't work. The DSM-5 recognizes that substance use disorders are marked by repeated behavior despite negative consequences. Yet the fundamental basis of our system of treatment relies on the belief that if we just punished enough people, we'd cure them of the disease. Take, for example, incarceration. We know that upon leaving incarceration, people have a much greater risk of overdosing. In fact, the reentry population is one of the highest risk groups for overdose. And this, of course, is due to the fact that when they are incarcerated, they don't receive evidence-based treatment and they withdraw from opioids. And if they go back to using at the same rate they did before they entered, that puts them at greater risk for overdose. So if punishment cured, why doesn't incarceration work? So the fact is that for far too many people, incarceration only exacerbates their condition. So again, what was initially perceived of as this singular issue where you can demand a crisis response, like removing a child from a home, has moved to a chronic issue where we need the longer term sustained response. Today, media attention has rightly shifted to the COVID-19 and the coronavirus pandemic, but that doesn't mean that the overdose epidemic has disappeared. The opioid and overdose epidemic coexist, and overdoses have increased in 2020 during the pandemic. One significant issue that's really gone underreported is the effect that the pandemic has had on harm reduction programs. A survey was released in April of this year, and it found that 43% of syringe services programs nationwide had reduced hours due to COVID. These programs provide needed services to some of the most at-risk populations. So when we exit this pandemic, and we will, we'll be left with an overdose epidemic that has worsened. And the slight dip in overdoses that we saw in 2018 will have evaporated. The Centers for Disease Control and Prevention won't release final overdose death numbers for 2019 until later this month. And rates appear for 2019 to be up about 5%. And so far, the preliminary data from the CDC shows that rates of overdose death in 2020 have increased by approximately 13%. We're on track to surpass the record high of overdose deaths. And if trends continue, we could be on track to pass the 80,000 death mark in the next 2 years. So what are the steps that we can take as we enter this third decade of the epidemic? And I think there are really 3 things that we can do. First, we have to recognize that stigma and discrimination pervade our nation's approach to addiction and to people with substance use disorder. We are definitely beginning to see some hope as there is more understanding of addiction as a disease. But we do often see, too often, that when loved ones die, of an overdose, we shroud their death in stigma and secrecy. And that's not the fault of the family. That's really the fault of us as a society, that we don't look at substance use disorders and addiction as what one would call a casserole disease. These are diseases that people are ashamed of. They're ashamed of, they think they did something wrong. And so, and surveys do show that about 15% of people who don't receive treatment don't do it because they're afraid that seeking treatment would have an effect on their jobs. So one thing that is happening is there is more litigation, an increase in litigation to protect the rights of individuals with substance use disorder under the Americans with Disabilities Act and the US Constitution. So litigation has been brought on behalf of people who have been prescribed medications for their opioid use disorder, and but are told that they have to stop using in order to enter jail or prison and when they are incarcerated. But cases have been brought across the country that have found in favor of the individual receiving medication-based treatment, because people with substance use disorder, like people with other conditions, have the right to receive medication if they choose and if their doctor chooses for their condition. So the second thing we need to do, in addition to addressing the stigma that's attached, is we have to expand our treatment and prevention workforce. So there is an adequate number of professionals to treat people with substance use disorders. The addiction workforce is under tremendous stress, and many areas of the country are treatment deserts. Now, Congress has appropriated funds to build this treatment workforce, but there remain large swaths of the country with inadequate access to people who can provide medications, to treat opioid use disorder, and to provide evidence-based care. Third, we need sustained funding to adequately address the addiction epidemic, to prevent these conditions, and to sustain recovery. So in 2016, Congress appropriated what at the time was a record amount of money. It was $1 billion, went to states to close the gap between those in need of treatment and those who had received it. And Medicaid expansion around the country has also allowed people, more people, access to treatment. But barriers to treatment remain, and barriers such as requiring people in the beginning stages of extended stage of methadone treatment to go daily to receive their methadone dose, a special licensing requirement before prescribers can provide buprenorphine treatment, a lack of adherence to parity standards, parity requirements, and overlapping state and federal regulations that really appear to have the goal of discouraging treatment access rather than encouraging treatment. So today's addiction and treatment and prevention systems were certainly not created overnight, and they won't change overnight. It's going to take sustained effort. But first, we need to acknowledge that the treatment system is really broken. And a system where only about 10% of people with a substance use disorder receive treatment is really broken. So as we enter this third stage of the overdose epidemic, we can't lose sight of how serious the issue is and the steps that have to be taken to reverse the epidemic once and for all, to provide people with prevention services and the treatment they need so we can truly move from rescuing people to long-term sustained recovery. Thank you very much.
Hi, I'm Dr. Kathy Slimp, former commissioner with the Bureau of Public Health in West Virginia. I'm really excited to be here this afternoon and to welcome you to our Huntington, West Virginia City of Solutions session. I think we'll hear lots of wonderful things that are happening here in one of our local communities. It really is the story of a community that's been tackling the substance use disorder epidemic. It's been one of the most heavily hit communities in our state and around the nation, really, and it's an inspiring story, really led by many of our panelists today. And these are folks that I really am proud to call colleagues and friends. Our first presenter is going to be Dr. Bob Hansen. He's the former director of the state's Office of Drug Control Policy, but previously was really the architect and a driving force behind many of Huntington's initiatives and approaches to the substance use epidemic. Our second person is going to be Connie Pretty. She is with the Campbell County EMS partners in our first responder community. But she really brings both her nursing skills and her heart to the effort, especially around our quick response team programs, which she'll talk about. Dr. Mike Kilkenny is our public health officer for the Campbell County Health Department, Campbell County Health Department, and among other efforts has started the first harm reduction program in the state and is really the public health voice behind the efforts in Huntington. And then our last panelist is Dr. Zach Hansen, who is the medical director of the Division of Addiction Services with Marshall University School of Medicine and has really been the medical support and expertise for one of our one-stop shop initiatives called PROACT. And he can share that story as well. So without further ado, I'd love to just here, I'll give you a very brief, this little context about substance use in West Virginia. As you may know, West Virginia and Eastern Kentucky is really the epicenter of the nation's opioid crisis. And we really have had quite converging factors that really had that increase occur.
Who were you asking about? What are we going to do about the time?
Hi, Carmen.
I'm sorry.
Hello? Or do we need to go ahead and continue, or? I'll jump back in there then. So we've had many risk factors in West Virginia that converge with the rise in the use of prescription opiates. So we had some of the highest rates in the nation across West Virginia. And pre-COVID, I think we peaked in our overdose deaths in about 2017. And then we began to see it level off and begin to decline, but we were still way too high. The US rates for overdoses are about 21 per 100,000, and West Virginia is double that at about 52 per 100,000. But of course, that only just captures one statistic, and there's so many other impacts, no doubt, with the substance use disorder epidemic in our state, whether it be from hepatitis and HIV or foster care system impacts, et cetera. There's definitely been a sense of urgency and a need to act. With that, I think it's really critical to put Huntington in context. It's a town along the Ohio River, part of Cabell County. It's the second largest town in our state. And historically, it has actually had the highest rates of overdose in West Virginia, 3 times the state rate. So while the nation was at 21 per 100,000, Cabell County was at 164 per 100,000. So enormous impact there. But this is not a story of despair. It is really one of collaboration and hope and impact. And so I think that our presenters can speak for themselves to show that. You'll see that from them as we begin to kind of hear the story of what's occurred. So I'm going to turn it over to Bob now to speak to some of that initial early work and some of the work that he's done to bring partners together and really shape an initiative that's making an enormous impact across West Virginia, not only in Cabell County, really, but much of what they have done in their road to solutions has been implicated and used elsewhere across the state. So Bob.
Thank you, Kathy. Good afternoon, everybody. I'm Bob Hansen, and what I'd like to do in the next few minutes is really just sketch the history in Huntington from being branded as the epicenter of the opioid crisis in the United States to now Huntington is getting to be known more and more as the city of solutions. So I'm going to talk about several concepts that really allowed the city to evolve and our county to evolve to be a place where solutions can be born and are born. The first thing I want to talk about really is leadership, because I think was such a key, especially in the early years. If you're thinking of 2015, 2016, even into earlier than that in 14, as we were in the throes of overdose fatalities, and really pressuring our first responder system. Huntington was blessed with many people stepping up, and in particular, I think the person to me that deserves a lot of credit, because it was at risk that he spoke up, was the mayor of our city. And just like many other politicians and city and county officials, our first response was to arrest our way out of this problem. But, our Mayor Steve Williams, who is still mayor today, really realized early on that this was much more of a bigger problem than anything that we could do through the arresting our way out of the problem. So one of the actions that the mayor took was to create the city Office of Drug Control Policy, and had a variety of 3 individuals that worked within that office. And those individuals really set the tone for discussion about what was going on in our community. So it's kind of a stage setting situation where we're honestly talking about it. Now, we know about stigma and that type of factor, but and that certainly was prevalent, and it is prevalent to a degree today. But it gave us an opportunity by creating the city office. It gave us a vehicle to talk about what was going on in our communities: the higher crime rate, the increase of overdoses, the increase of fatalities. And it brought people together, and it brought the city and the university, Marshall University, together. And the president of the university had a committee and actions taken. So the university was throwing its resources to address the problem. So we had this phenomenon talking about what can we do, describing it, being honest about what was going on in our community. So we had this leadership that allowed us to move into communication about what was going on. And then that fostered collaboration. And to me, that was the key to moving from the epicenter concept of all the problems, but now we're focusing on multiple solutions. And the speakers after me can talk to you and describe some of the solutions that we have developed and implemented. So really, that's what happened, is communication became a collaboration. And then in August, as we had that terrible day of multiple overdoses over a 4-hour period. And I think that became a catalyst. One is thanks to the studies that the state public health and Dr. Kilkenny at Cabell and Huntington Health Department did. We were able to save lives, but what became really glaring to us is, what do we do next? And that was a catalyst for us to begin looking at solutions. And that collaboration continued and spread throughout our community, where agencies and entities were working together to come up with solutions. That happened to a point that the rest of the country, certainly the rest of West Virginia, was becoming aware that Huntington was doing something about this opioid crisis. And it led to the development of really a book of all the different services that we've developed in Huntington. And the book was titled Huntington City of Solutions, which we began sharing with other communities in West Virginia about what we were doing in Huntington. So really, if you had to give credit, it was taking a risk, facing problems head on early, doing something about saving lives, helping people recover. And we've been blessed to be living and working in a community where individuals have been very proactive in wanting to do something about this problem. And over time, before COVID, we were demonstrating a lot of positive data. COVID is obviously another mitigating factor related to overdoses, but it has set us up to continue onward to make Huntington even more effective as a city of solutions as we go forward. So, Connie?
Good afternoon. My name's Connie Pretty. I am the Huntington QRT Program Coordinator, and in essence, the QRT is a quick response team that goes out after someone has had an overdose event. So I'll give you a little bit of background on how this all came about. Bob is exactly right. I always call him the corraler of the cats, because he got everyone in the same room together. We all realized that we were facing an issue that was bigger than ourselves, but everyone saw it from their own point of view. So we were able at that point to say, we do have this common issue. Our goal was to help. We did have the political side on our side. We had the public health on our side. We had Marshall University. And I was lucky enough that I was on that EMS side. And in 2014, we had created what I call as a drop-down box for our electronic medical record. So we were able to start tracking overdoses accurately. That box was selected by our medical professionals in the field. So we had a really good sense of where our overdoses were going. And we saw them just trend upwards 2014, 15, into 16. And as Bob said, in August of 2016, we had 27 overdoses in about a 4 or 5 hour period. That made not only national news, but international news. But the glaring thing that we found out from that was that not one person entered treatment after that day. We did an excellent job of saving lives that day. Everyone that EMS contacted that day, life was saved. We had a few people that went into the ER by personal vehicle, but we had a really good outcome from the life-saving perspective, but just a horrible outcome from that next step. So that's when we got together. That was when I was lucky enough to start working with this group in late 2016. And we got this model presented to us. Bob recruited a group in from Coleraine, Ohio, that had this quick response team model. Since then, we've modified it on a national level. It's called a first responder diversion program. So what it is first responders. We have police, Huntington Police Department, Cabell County EMS paramedic. We also have a treatment provider, and as I know, still the only organized faith leader that goes out with the team in the country. And we utilize EMS data to determine who we need to go see. And every day I run those charts, and also the paramedic that's the team leader can run those charts. We've got an agreement through all the agencies to share that protected health information. And they literally go knock on the door of someone who has had an overdose event. Very quickly, we found out that people would say, so do you have to overdose to get help? And we are like, absolutely not, even though we were funded by 2 federal grants in the very beginning that specified this is for overdose, opioid related overdoses. We realized that we needed to help anyone who asked for help, and we developed a number. It's not a hotline, but it is an access number, and people utilize that all the time, especially families will call us. If they've reached out to us, they move to the highest priority. In 2017, which didn't get as much publicity as the 2016 event, our overdoses continued to increase every single month until we were averaging about 6 overdoses a day. And this is a city of 50,000 people. So it was just a tremendous issue here in our community. And we realized this was a very difficult system to navigate. As I was a flight nurse for 25 years, and I would hear people say things like, I tried to get help, but I didn't know where, or I tried to get help and there was no beds available. And in our very cynical way, we said, yeah, right. And now that I am part of this, I realize how difficult the system is to navigate, and that you really do need that compassionate hand to reach out to you where you literally are and offer information. We will actually start the intake if an individual says they're the least bit interested in any type of treatment, and the team continues to go back and visit until they sort of pretty much exhausted the individual. So one of the sort of concrete objective things we were able to do was we were able to track those overdoses over that next year. So the team actually made their first visit in December of 2017. So I was able to track those overdoses all through 18. And I'm certainly speaking to it from the quick response team side, because I know everybody's effort added to this very an excellent outcome was that we had an overdose rate decrease of 40% in 2018, between 2017 and 2018. And it was that collaborative effort and having somebody in the field we felt was really driving those numbers down. one of our researchers that I work with through Marshall University, I said, did we just reach a tipping point where it was time for the overdoses to go down like we do with any other epidemic? And he said, Connie, there's two reasons when you have a dramatic change like that. And he said, it's either death or intervention. And he said, we performed an intervention that has had an impact on this crisis. So the quick response team really quickly realized that they were going to fulfill a lot of different needs. They became almost like social workers. A lot of individuals did not have IDs or food or housing, and we were able to connect them with a lot of services on that level. We were able to, now we can get them state funded medical insurance with one call because we've developed those types of relationships. As a first responder in the field, a lot of times at the overdose scene, things were confrontational. People were not very receptive. Our crews were probably not very nice. People were embarrassed. They wanted to, especially if they've been revived with Narcan, wanted to get up and leave the scene. They're in a public place. They want out. So we weren't 100% sure if this model would work, where we were actually going to them and interacting with them where they live. But within the first 2 weeks, we had individuals say things to us like, so you're here to check on me. You cared enough about me to come to my house and knock on my door. And it really had an impact. It's continued to have an impact. Now, when they see the vehicle come into the neighborhood, they come over, they talk, they visit. Our team will go into the public library here, or the homeless shelter, or to local gas stations and interact with individuals. And having that first responder mix, you have EMS and police that are on the streets quite frequently. So they're really familiar with the individuals. We had one peer recovery coach that we said knew everyone in Huntington. So it's really sort of neat to watch this interaction, because you have very varying backgrounds, very different points of view, come from very different walks of life. Even EMS and police don't see things eye to eye. And to see the team laugh and joke and enjoy their job and genuinely care about the people that they're seeing, it's very heartfelt and warms my heart, because I've been a nurse for a really long time and you tend to get cynical. So it's very rewarding to see that kind of interaction and that kind of care. And we had to actually tell them, don't take the phone home with you. Don't answer it at 1 o'clock in the morning, even though they were wanting to do that. So we've had really good results. We refer people that are not ready for treatment to the health department for HIV and hepatitis screening, and also for their harm reduction program. And we've worked really, really closely with Dr. Kilkenny to help individuals until that point that they might be ready for treatment. So this model has worked well. We had one of our grants through the Bureau of Justice Assistance that has adopted this model on a national level and actually developed a mentor site program. And our intention was to bring individual groups from communities all across the country to 7 sites in the country so they could learn firsthand from these sites. And we were selected as one of them. And then COVID hit. So we've only been able to interact virtually so far. But maybe at some point we would love to have individuals from across the country come here.
Those are wonderful chances to really learn from each other. Absolutely.
Absolutely. So
thank you.
That's just a quick overview, and I'll just move on now.
Thanks. Mike, let's hear a little more from the public health perspective and what you've learned over time with this.
Thank you, Kathy, and thank you for the team for inviting me. Kathy, I'm going to have to correct you, and that's a very rare instance that I ever get to correct you. But the people who actually started the first harm reduction programs in West Virginia would take issue with you giving that credit to me. We did start a harm reduction program in a health department, and that model has been successful in the state of West Virginia. But there were a couple of programs open before ours was.
True.
Kathy and Bob have both described some of the dire circumstances in regards to hepatitis, overdose death, and other conditions that are associated with injection drug use in Cabell County. In 2019, we actually had an HIV outbreak, which was the second largest rise over baseline in any American community after Scott County. And we have worked diligently since 2014 when the mayor set up his programs, 2015 when I came on board at the health department, and join forces with everybody on this panel, plus numerous other partners in Huntington, and everyone on the panel can tell you we all know each other by first names. We all have each other in our phones, and we just call each other up and we work together to solve any problem. But the health department's goal was to change statistics. We are happy for people to feel better, and we're happy to issue help wherever we can, but our real goal is to change the statistics. We were extremely gratified to see overdoses reduce after the QRT came into being, and after the other interventions like the community naloxone distribution program that we instituted. Our pharmacist for that program just won a national award from the American Pharmacists Association for his work in saving lives using naloxone in our community. They've mentioned the day in August of 2016. The health department after that day used its reportable disease rule to investigate that outbreak of overdose as a disease, and we were able to describe it. We were able to determine that for those people who got medical attention, there was no loss of life. We were able to identify it as a carfentanil event when carfentanil was brand new. And we were able to identify that no one who went to the emergency room that day got referred to care for their substance use disorder. Those days have changed because of that work. We now have programs in place where people get referrals, where people get treatment for their co-occurring illness while they're in the hospital. And our outcomes are very different today than what they were. We've worked with many, many partners at many levels. We had CDC in to help us with that description. We had CDC in to help us with our HIV outbreak. We actually got that outbreak controlled. It was essentially stopped in December of 2019. And then COVID came and took away our hands-on impact. This is a hands-on group of people we're working with, and without that, we've lost ground. We know that when we control COVID, we will have to work to regain that ground and get back our HIV control. But we also know that we can do that. We've had a great deal of success describing our population, doing population counts. We've worked with researchers from Johns Hopkins to the University of San Francisco to describe our population so that we could work with them, and to describe it by talking to the people who are suffering from the disease and not guessing what's happening based on their toxicology reports. So we think that we're on the right track. We think that we've been very vigorous in our work, and we're looking forward to the day that we get to interact face to face and arm in arm like we did before COVID, and get things back under control from that standpoint. Since I've been the health officer, we've had syphilis outbreaks. We had the multi-state hepatitis A outbreak. We've had an HIV outbreak. We've had a pandemic. And next year, if flaming pitchforks fall from the sky, we'll take care of that too.
Thanks, Mike. It's no dearth of activity that you have done as health department, but clearly it's really done in partnership with the community. That's the key thing across all of these. You spoke of a hands-on, and this is a one-on-one and individual relationship with our substance using population and the challenges that they are facing. Zach, talk a little bit about the medical side, the treatment side of what you're seeing in the community, and how that work is really being innovative in a lot of the work that you're doing.
Well, thanks everyone for having me, evening or afternoon, wherever it may be for you. You know, as a medical provider, you know, I've been out of residency for about 15 years. And so I distinctly remember sort of the transition from controlling pain as the fifth vital sign into sort of the place that we're at now. And for the longest time, you know, we had a hard time as providers sort of making that transition over from sort of treating pain to understanding that there was some harm that came from that. And, you know, with that, there created this stigma within the medical community, you know, that this patient population was sort of a scary population, or a population, you know, that couldn't be trusted or wasn't motivated for change. And as sort of began to work with them over time, over the last 10 years or so, couldn't disagree with that initial sort of assessment and people's beliefs more. You know, working in this population, really, I always say, is sort of, it's the stuff of entrance essays. And so if you think back to what medical providers probably put in their essays to get into medical school about making a difference in their community, in my mind, there is no greater difference that can be made in sort of tackling the opioid epidemic in your local community. And it's a chance to make a discernible difference. You know, so much of what we do primarily as a primary care provider is sort of treating patients for the long haul, hoping to prevent some sort of catastrophic event, whether it be a heart attack or stroke or complications from diabetes. But when patients walk in with a substance use disorder and you have a chance to sort of treat them, you can see a discernible difference even within a week or 2 weeks, and definitely within a short period of time in retrospect, and you can see lives change. And that sort of gratification, you know, as a medical provider, it's honestly, it's the stuff that you dream about, you know, when you go into medicine, is to make that big of a difference in that short period of time. You know, and for primary care providers, we have a unique opportunity to see the whole patient and treat them regardless of sort of what their needs are. And so it's really opened up, I believe, definitely has opened up my eyes. And as I've talked with other sort of providers in the community, we've been able to sort of to see, you know, how rewarding it can be, you know, and of all the providers that have started to treat sort of through our programs, I mean, not a single one has come in and then quit after a couple months, you know, or walked away. Every single one of them has wanted to do more and has recruited friends and family alike to come in and sort of get on board with what we're doing, which again, it speaks volumes about what we're able to do, and these patients that everybody thinks you know, are so horrible, that are actually in many ways, you know, can be the salt of the earth and are fabulous to treat, and so appreciative. So, you know, sort of doing MAT, you know, how to sort of building an MAT program or medication assisted treatment program. Yeah, these are patients typically that are very good at detecting the truth and not the truth, to put it politely. And so, if you're able to show that you care, you've already met them halfway. You know, as Connie has said, just showing that you care is a difference maker for these patients. You know, the majority of them have probably been belittled and made fun of and criticized and just torn apart for most of their lives by friends and families. And to sit down and talk to them face to face and show that you care really is the first step in significant change in their life. You know, we find that just by doing that, we're able to get a very consistent flow of referrals from family and friends, because, you know, I believe it sets our providers apart from some of the other providers in the community, and it's really helped us be successful. I would always encourage, you know, to look at an integrated care approach. If you are doing MAT, you know, we speak of collaboration at our facility. We have therapists that are on site. We talk almost daily in the hall or in the office, more in the office now with COVID, but we talk through patients and determine what the best course of care is. And that's made a huge difference. And it's also made it a lot easier to keep patients accountable to their treatment program. We also sort of found in building a program, you know, that we were never probably in Huntington going to be able to recruit someone to come in and do a really, really large practice, or someone that was board certified sort of in addiction medicine. And so we've taken this, everybody does their piece sort of feeling. And so we have an ER physician that may come in and work a half day and see 30 patients. And then we have a family medicine doctor and an internal medicine doctor, psychiatrist, always, you know, not to make fun of this gentleman, but we had a neonatologist who was a very smart man, and he came in and started working a half day and said it's the best thing he's done in 30 years in medicine, and just absolutely loved the interactions that he was able to do. And through doing that, you know, by piecing it together with everybody doing their part, we were able to grow the program. You know, at one point pre-COVID was probably up to 600 or 700 patients total, which is fairly significant, you know, in a town that's, you know, 50 to 60,000 patients total. So we built an organization called PROACT, which stands for Provider Response Organization for Addiction Care and Treatment. And so it was a collaboration between our two local hospitals, Cabell Huntington Hospital and St. Mary's, as well as Marshall University, Marshall Health, which is the medical practice arm of the med school, and just determined that everybody needed to work towards their strengths and be open about what their weaknesses are. And then we would find somebody who had that strength to sort of fill in the chain. And we were able to sort of create a comprehensive program in which we have medication-assisted treatment, but also absence-based treatment. We have peer recovery coaches on site. We have case management to help with transportation and housing and food and childcare, etc. We have a spiritual mentor. We have a creating opportunity recovery employment. So we are looking at employment opportunities for our patients, which is great to help them not only get sober, but also create a life again by being able to work and provide for their family. And so by everybody doing what they're good at and putting it in one location, we've had some amazing sort of success and been able to grow and integrate a program that has really been sort of groundbreaking for the community, and hopefully, you know, groundbreaking, you know, regionally and across the state. You know, and all that began because of the collaboration.
That is a great thing to end on there. I really think that that I think all of our partners here today will talk about the collaboration and the coordination of services. There was a question related to Connie about the harm reduction supports that were offered during the QRT work. And I know they do a lot of naloxone supports. And I think that people have and a lot of referrals. There's been some integration of other efforts as well. The only last thing I might pose out to the group is how have things changed with COVID for you? And what have been any innovative ways that you've been able to really address that, keep this work going? If you can think of one quick thing, if anybody that can throw those out, that could be just an innovative, exciting opportunity that somebody else might think about as a lesson learned or a best practice?
Well, at the health department, we've tried to get some of our services out of our building and into the streets and into the community, and that's one of the shifts that was beneficial all the way around, but COVID drove it.
Great.
I think for us, I mean, we've sort of done a little bit of a shift towards maybe on the pendulum more towards harm reduction, in which we said, we have barriers to treatment. We can't provide the level of care that we would like, but we need to provide some care and be there and support the patients through this. And so just putting forth the effort, makes a huge difference in trying to keep the patients engaged. And if we can keep them engaged, if we can get COVID over, then hopefully we can sort of ramp up the services and start making a larger difference in the long run.
Really does. I know naloxone has been a big effort statewide. There was Bob helped to coordinate or spark the ideas for a naloxone day, a Save a Life Day in Charleston, and they're exploring that in Huntington as well. So this whole push to really expand our naloxone use. We've also passed legislation that allows community organizations to train on and distribute naloxone as well. So lots of efforts in that arena. I think, unfortunately, we're going to have to wrap up here. I just want to thank our panelists. You always inspire me with your enthusiasm and your commitment to the work. And Huntington has really been an opportunity to really show how coordinating services, integrating services makes such a difference. I know Connie spoke to the fact that it's not, that it's changing statistics, and it has. We actually saw overdose deaths drop in the Huntington and the Capital County area by 25% last year, or in 2018, which was an exciting turnaround time. But more than just the numbers, it changes lives. And I think that's what's been so exciting and so inspiring. So thank you to everyone, to the work that you do, and wishing everyone happy holidays. Thanks. Bye-bye.